Hello, Alyssa. Hello, Dr. Ryan. We'll get started with the virtual town hall in just a few minutes. We'll give folks a little bit more time to get logged in. Yeah, I'm good. What do you guys think of my background today, this month? Oop, you're muted, Alyssa. They're not muted. Oh, they can't. Let's see. Can you have your volume up?
Can you hear me now, Chris?
Yeah, I can hear you. Let's see. Ask. Make code. Did that work?
You just unmuted me. It might be under like participants, and then there should be like a 3 little dots where you can say whether you're allowing us to unmute or mute ourselves.
Yeah, I thought I had hit that already, but let's see.
Let me try to mute myself again and see if I can unmute myself.
No. Allow panel. It says allow panelists to unmute themselves, and it's. Let's try that. Is that?
Yeah,
now?
I'm good now. Yep.
Great. All right. It must be opposite day for me. All right, well, we'll go ahead and get started. Nice mug. We will go ahead and get started. We'd like to welcome everyone to our 10th COVID-19 virtual town hall. And I'm coming to you live from the beautiful Georgetown Heritage Center in Georgetown. So we're trying to hit different spots around the county to highlight them. And just real quick housekeeping, this is a webinar. So the only the panelists are shown on screen. Anyone who is listening in, you are not on screen, but please feel free to type in questions and comments in the chat and the comments on Facebook, and we will get to those as we can. I'd like to welcome Dr. Tim Ryan, Clear Creek County's Public and Environmental Health Director, and Alyssa Dinberg, Clear Creek County's Recovery Coordinator. And we have a lot of information to provide this month. A lot has happened since last month. So I think let's kick it off with Alyssa to give information on Clear Creek County's recovery plan and the American Rescue Plan Act. So go ahead, Alyssa.
Thanks, Chris. Hi, everyone. Can you see my screen? We're good?
Yep.
All right. So if you haven't heard, I'm going to go over our American Rescue Plan Act. These are dollars that are coming into the county that will be used on recovery efforts. So just a quick overview about what the recovery plan is and how, or the American Rescue Plan is and how it compares to other plans similarly. So in 2009, the American Recovery Reinvestment Act, that was 800 billion. The recovery package in March of 2020, which was due to COVID, was 2 trillion. The recovery package in December was 900 billion. And then the one that we're talking about today is 1.9 trillion. So I just wanted to compare it to other similar packages that the federal government has released. So a quick overview of the summary or of the plan. State and local governments are receiving money, education is receiving money, transportation, capital projects. There's a program specifically for home assistance emergency program, rental assistance, small business support, COVID-19 response, and then individual assistance. So what we're talking about today is going to be that state and local government dollars. Those are the dollars that are coming to our county. And then we'll just quickly overview some of the money that's going to the other areas as well. So there's going to be $350 billion that goes to state, local, and territorial governments. Our money is coming from this little sect of this money. Rental assistance and eviction moratorium, as we all know, it has been extended. Since it's been extended, they've also put dollars into a rental assistance program to help with evictions. So if you know that somebody is facing eviction or struggling to pay their rent, there is a federal program that's been given, they've given money to the state to administer the program. So if you have anyone that you're concerned about, we have money for those individuals. Assistance for small businesses, there's going to be $15 billion put into grant programs for small business owners. And this is separate from the existing Paycheck Protection Program. So if you're a small business owner, I'd highly recommend you looking into resources for your business. Vaccination and testing, more dollars put into this, trying to get the vaccination rates up and also encouraging testing for those people that are showing symptoms. And then our county allocation, I want to talk about how much Clear Creek County received, but I also want to highlight how much the 4 municipalities have received as well. So Clear Creek County received almost $1.9 million. Idaho Springs is receiving almost $500,000. Georgetown's about $280,000. Empire is $76,000, and then Silver Plume is $44,000. So all together, the county is receiving $2,733,407 from the American Rescue Plan Act, which is fantastic. Something exciting, hot off the presses, we just got our first allotment from these dollars today. The way that these dollars work is you get a first tranche. And then a year later, you get your second tranche. So that first tranche just hit our bank account today, which is very exciting. So that was $942,055.50. So some uses of funds. And the reason that I think it's really important for everyone on this PowerPoint, or for everyone on this webinar to know this, is that we're going to be coming to you and asking you for your feedback. We want to know how you think these dollars should be spent. So that's just a little teaser for what's coming. Keep your eyes out for invitations to those meetings. So the use of funds, they can support public health expenditures. They can address negative economic impacts caused by the public health emergency. They can replace lost public sector revenue due to COVID-19. They can provide premium pay for essential workers and then invest in water, sewer, and broadband. Some ineligible uses of those dollars are deposits into pension funds, debt services, legal settlements or judgments, and then deposits into rainy day funds or financial reserves. So again, as I said, we really want to engage the community in this process. This is just the first part in educating everybody. We will be coming to you at a later point in time to help us think through how we're going to spend these dollars. We have until 2026 to spend them. And so we want to make sure that we're really, really thoughtful with the uses of these dollars. It's pretty broad. The guidelines are really broad. And so we think there's a lot of good that can be done in our community. That is all I have about the American Rescue Plan. Do I have any questions in the chat?
Yeah, I'm not seeing any questions in the chat, but I have a couple of questions that people have kind of been coming to me about, so I thought I'd share with you.
Sure.
You recently sent, or earlier this year, there was a COVID impact survey that went out. Will the results of that survey be used in figuring out how to allocate some of these dollars for ARPA?
Yeah, absolutely. And we're already using the results of that survey to help guide some of our decision making. I think a really good example of that is with vaccinations. One of the questions on that survey specifically asked, do you intend to get vaccinated? And we're using those results to help us use some of our remaining CARES dollars on a paid marketing vaccine campaign. And that question really helped us identify how many people in the county actually are interested in getting vaccinated and may just not have had a chance to, don't know where to go, or maybe just need some more information. But yes, the other answers on those questions will absolutely help guide the ways we use these funds.
Okay, so you mentioned that survey was put out with respect to the CARES money primarily. So could you just remind us again? So there was a CARES fund allocation that was given, and then this ARPA is a separate chunk of federal dollars.
Yeah, so the CARES funds are one of the little spots on that timeline on that second slide that I showed. They were released, I believe, I can just pull it back up, in 2020, in March of 2020, and that was $2 trillion. So it's a similar package, different uses. CARES dollars were really intended to be emergency relief. And so that's why the majority of those dollars went to our businesses, individuals in our community that were facing financial hardship due to the shutdowns. Those dollars were really almost more like a Band-Aid to keep the community together. These dollars are going to be more long-term sustainable solutions to some of our big challenges.
All right. Justin is asking, what were the results of the survey in regards to who would like to be vaccinated and why allocate money marketing to the vaccine if people aren't interested?
That's a very good question. So I don't have the results right in front of me. At the next town hall, I'm happy to present those. If people are interested, I'm more than happy to do that. The answers on that survey were, yes, I intend to get vaccinated. I don't know if I want to get vaccinated. No, I do not want to get vaccinated, or I've already been vaccinated. And so what we did is if they've already been vaccinated, we're not focusing on them. If they don't want to get vaccinated, we're not focusing on them, because we're not trying to change minds. We just want to encourage people that don't know or potentially want the vaccine, just haven't had access to it. So that's really the main focus of the data that we've used for it. The yes, I want to get vaccinated, or the don't knows, and that percentage is what our target audience is.
That makes sense. We had information on that original survey on our county COVID webpage. Will we be putting the results of the survey on that webpage also?
Yep, that's the intention, to put the results on there. We just need to put it in a way that makes sense for everybody. I want everyone to have access to all the questions and the combined results from it.
Awesome.
And just a reminder, there's no personal identification. There's no individual responses on there. It is just the unified percentage for each response.
Great. If people have questions about the remaining CARES dollars or are interested in applying, is there still money left, and can they still do that?
Yeah, that's a good question. So the business program is closed, our business grant program, and our individual support program. The money that we got from CARES, we put $51,000 of CARES dollars into that program. That money actually was spent by the end of 2020. There was a significant need in our county. We went ahead and applied for a $100,000 grant to Mile High United Way, received that, which was fantastic. And that money actually just expired about last week. So that program has since closed as well. And the remaining dollars, there's internal conversations right now on the best use of those dollars. If anyone has any questions, please feel free to reach out to me. I'm more than happy to share how the money has been spent. If it'd be helpful, I can do another presentation here. I know I did one a couple months ago on where those dollars went. I'm happy to do another one.
Okay, great. Do you want to just let everyone know your contact info, Alyssa, in case they do
I'll-
want to get with you?
I'll put it in the chat. How about that? I
Okay,
think
that's great.
Zoom changed their features, so I can now put it in the chat so everyone can see it. And then if we could just put it on the Facebook thread as well, that'd be great.
And also it is listed on our COVID webpage. We have an info box with all the contact information for people who are associated with COVID efforts.
Yep, and I'll put my cell phone number. Feel free to text or call me. I'm more than happy to communicate that way if it's easier for some.
Awesome. Well, thanks so much, Alyssa. We know you're doing just an incredible job finding the dollars, applying for the dollars, and working on getting the money spent in the most effective way to help Clear Creek County residents. We really appreciate it.
Thanks, Chris.
Let's see. Okay, there's your contact info. So just let us know if you, again, reach out to Alyssa if you have any questions. You can also reach out to me as the COVID Public Information Officer, and I'll get you connected with Alyssa as well. So it doesn't look like we have any other questions regarding recovery. So I think, and there's your cat. I see your cat behind you. We can go right into COVID updates with Dr. Ryan.
One
Oh,
second.
wait. Let me just stop. Just real quick, someone asked, last year there was a grant for the school lunch program. Do we have that this year? And Karen Quambeck just answered, yes, the grant for the school lunch. Yes, there is that grant. So I'm sure the school district will be sending out information on how to access that. And they typically share that information with us, and we'll get that on our website as well. So great, thanks. All right, Dr. Ryan.
Can you all see my slides?
Yes.
Excellent. Good evening, everyone. Thanks for joining us tonight. We'll just get started right away. So lots of numbers, lots of data. We'll go through it and then answer questions after that. So we'll start with the US trends and what we're seeing across the country. This chart here shows the daily trends and number of COVID cases across the United States as reported to the CDC. As you see on the far right, the incredible slope that's going up. We are now averaging around 141,000 cases per day as a 7-day average in the United States. This is a breakout by age. COVID weekly cases per 100,000 population. The gray bar on the far right indicates what is in essence a data lag, a 2-week lag. So what you see in that bar is not actually representative of what's going on or what has already happened. But just before those bars, you see all the lines going up in the upward direction, including the 0 to 17 indicated here in yellow. All of those are increasing. The lowest increase, I should say, among age groups is 65 and 75 plus. That is the most vaccinated group in the entire country as an age group. We'll talk more about that in a bit. This is new admissions of patients with confirmed COVID cases across the entire United States. As of Tuesday, 2 days ago, there were 88,000 plus Americans in the hospital on Tuesday. So as you can see here by this graph, the number is going up exponentially and quite quickly over the last literally 3 to 4 weeks here in the United States. More specifically, every age group under 50 has surpassed its previous record of hospitalizations to date over the last several weeks. The largest increase in those 30 to 39 and children under 18 years of age, both of which are 30% higher than the previous peak, which was sometime in mid-January. As you see this line straight up for those 0 to 17. Daily trends in number of deaths across the United States, as you see on the far right, is an upward slope. Do remember, though, there is a lag between case increase, hospitalization increase, and subsequent death increase. As of yesterday, we have lost 600 and almost 25,000 Americans due to COVID. That number is increasing by about 600 a day, and that average is increasing as well on a weekly basis. Here in Colorado, this is cases of COVID in Colorado reported by week across the state. I draw your attention to the far right of this graph. The blue line and the red line before it are incomplete data. Those do not reflect the reality of what is actually going on. But more importantly, you see a 29% increase over the prior week, followed by a 32% increase, followed by a 38% increase, followed by a 15% increase. And that 10% and blue line are not yet complete data. Both of those will go up in succession as the prior weeks indicate. More specifically, Colorado's pediatric case rate. As you see here in folks 0 to 18 and then 18 plus, all of them on the rise across all age groups in Colorado. I'm showing this one because I think it's a good indication of what we're seeing in several parts of this state. This is at Broomfield County. The black line that you see in the middle is the county average in number of cases in the overall county incidence. The blue line, the one at the very top, is those individuals who are aged 6 to 11. So you see the rate of increase among 6 to 11-year-olds is significantly higher than it is for the average in that county as a comparison of rates. So this new variant, Delta variant, which has been around for a few months now, is significantly impacting the young far more than the prior variants we've seen in this country. New admissions of patients with confirmed COVID across Colorado. Again, here on the far right, you see the gray area. Gray area indicates it is the data is not yet complete. Data is still coming in, and so those numbers will actually likely go up. Rarely, if ever, do they go down based on incomplete data. They only go up. So as you see the upward slope in number of new patients across the state, we currently have roughly 700 individuals hospitalized across the state in Colorado, and that includes both pediatric and adults. Our average is about 105 per day of new admissions as a 7-day average. Take a drink of water. Here in Clear Creek County, this is a summation of our numbers. We are currently at 236 cases per 100,000 as a 2-week average, 2-week cumulative incident, with 23 cases over the last week alone. The 1-week case incidence testing predominantly was done on Tuesday, so it will be likely tomorrow that number will increase on the 1-week incident rate. So our test positivity is at 7.8% currently across the county. Over the last week, we've had 3 additional hospitalizations here in Clear Creek County. There's a few more data slides that I want to show you that aren't directly related to COVID per se, but are very relevant to what is going on both here in Colorado and a number of places in this country. RSV is a respiratory illness that impacts generally the 5 years and younger. As this slide indicates, the peak usually happens much later in the year. Right now, we're seeing a huge spike, as you see here on the far right. This is comparing August of 2021, that right arrow, compared to August of 2019, just 2 years ago. And you see where normally RSV levels are sometime in August. This is particularly concerning because right now, RSV is not only in Colorado, but a number of states across the country, increasing at a level we haven't seen. It's coming much earlier. It's also coinciding with the reality of COVID and the increase in number of pediatric cases of COVID across the country and across the state. it's setting itself up for what is a perfect storm in the most negative way you could possibly imagine. Only a few months away is the flu season. And when you take RSV and COVID and the flu season combined, and all of those impact the pediatric population, most concerning is the number of hospital beds that we have in this state for the pediatric community. That number is less than 100 across the entire state. That's further compounded by the fact that Colorado plays a regional role, meaning there are many states around us that don't actually have any pediatric or intensive care unit beds in their entire state, not a one. So those states send their individual pediatric patients here to Colorado. So what is probably in the estimates are 50 to 60 beds across the entire state. Those pediatric beds are to be shared by a number of states. So this fact and this slide is what have many in the medical community very, very concerned about what's to come over the next several months in the pediatric world. These next two slides are an analysis that CDPHE did in the state epidemiologist, Dr. Herlihy, looking at those states who are a few weeks ahead of us in terms of being in school and mask mandates or no mask mandates. So what they did is they looked at Georgia and Indiana, which I'll show you next. And they did a comparison between school districts that had mask mandates in place and those districts that did not have mask mandates in place. If you look at this far right of this graph, the yellow line is indicated by, or the yellow line indicates those school districts that did not have mask mandates in place. A line that looks like this is what we call exponential growth, meaning day after day and week after week, it's growing exponentially. There doesn't seem to be any end in sight. This blue line is among those districts that actually had a mask mandate in place. Now, granted, this is only 2 weeks of data, but what they're seeing is this yellow line is continuing to go straight up. As they continue this analysis, we will be showing you this. These two lines indicate a significant difference in the number of cases between these two different districts. And there's several districts as indicated on here. What this tells us is that mask mandates do in fact have an impact on the number of cases that are seen in a specific district. And that impacts whether a school closes or not. When half of your student body and teachers are in quarantine, the school has no choice but to close down. So showing you now Indiana, we see the exact same thing. The yellow line indicates school districts with no mask mandate. The blue line indicates schools with a mask mandate. Significant difference in those slopes, significant difference in the outcome in terms of whether children can remain in school or children have to go remote. That's the end of my slides. More than happy to answer questions.
Okay, we've definitely got some questions coming in. So you pretty much covered this one. Someone asked, they commented that the upward trends don't seem to be affected by mask mandates. Why do we continue to implement mandates? But the most current slides that you just showed indicated the opposite of that. Yeah,
and let me be abundantly clear. The American Association of Pediatricians, the American Medical Association, NIH, CDC, the Colorado chapter of the American Academy of Pediatrics, the entire medical community, we are all in absolute agreement. We have all reviewed the data. CDPHE, we're all on the same page. Masks do in fact make a difference. Masks are effective at reducing the transmission of viruses, not only COVID, but RSV, flu, the list goes on and on. The evidence is quite clear. The medical community is in complete agreement. And many school districts across this state and others have in fact done the right thing in mandating masks. It is the only thing that we have to protect those under 12 who have not been vaccinated because they're not yet eligible. Short of masks, we have very few tools in our toolbox to protect those individuals. And so that is why the school district in this county and many counties around us have mandated masks, because it is the best tool that we have at slowing transmission. Is it 100% effective? No, nobody has ever claimed it has. It is, though, effective in reducing the transmission. And so for that reason, it is mandated.
And could you just clarify, the mask mandate for Clear Creek School District is for vaccinated, unvaccinated, youth, staff, everyone when inside a school building?
Correct.
Is that
so the current mandate in Clear Creek is for all people in the school, children and staff alike, vaccinated or unvaccinated. The primary reason and rationale for that is we do now know with the Delta variant, even vaccinated individuals can in fact get COVID and transmit it to others. The impact on that individual obviously is minimal compared to the unvaccinated, but again, it is another measure to reduce the potential transmission in the school. So all staff, all students, regardless of vaccine status, we need to do that at this point. Let me remind you, half of America is still unvaccinated, and 40% of Clear Creek County is unvaccinated. Only 33% of our student body in Clear Creek County, in the middle school, high school, obviously as the only eligible, are fully vaccinated. So we still have a significant level of risk and the potential for transmission, and that's why we have that policy in place.
all right? Someone is asking, I think this is when you were talking about the RSV. Could masks contribute to these illnesses, improper use of the mask, as well as people's immune systems not being exposed to these germs?
No, masks do not cause RSV. Masks have no role whatsoever in what we're seeing in RSV now across the country.
All right. Let's see, here's a comment and question. All of the COVID charts have similar trends, spikes in January and May, and another spike now. The spikes now are generally lower than the earlier spikes. This is even true for the pediatric cases. What is the difference now than in May?
The difference now, 99.9% of cases in this country are the Delta variant, which is 50% more transmissible than the UK variant, which is what we saw predominantly in May and the prior spikes to that. So the Delta variant is a very different enemy than what we've had in the past. It is obviously far more transmissible, and that's the reason why we're more concerned than we were then. And the spikes, the potential that this has is significant. We're trying to get out ahead of it, not wait till things blow up completely before we have any sort of measures in place.
Right. Could you talk a little bit about masks and the different types of masks and the effectiveness of the different types of masks?
Absolutely. So in this state, I know CSU was contracted by the state of Colorado to look at that very question. What is the efficacy of different masks? For instance, anything from one end of the spectrum, a gaiter, to an N95 mask on the other end of the spectrum. An N95 mask obviously is 95% effective, hence its name, at keeping anything out and protecting the person wearing it. Gaiters are on the other end of the spectrum, anywhere from, it highly depends on the material, it highly depends on the number of layers of material. All of those play a role in the efficacy of that mask. So gaiter is probably in the neighborhood of 10% at reducing transmission. A surgical mask is in the, I don't know all of these numbers and the efficacy of different masks. Would we like everyone to wear an N95 mask? Absolutely, that would be the most effective way at slowing or stopping transmission. Do we have enough in this country for everyone to wear one on a daily basis? No. Are they reasonable to wear on a daily basis? No. So it's about finding something that is comfortable and finding something that is effective as you can tolerate and wear. But any reduction in transmission is helpful. And so any mask is better than nothing, but we would always suggest that you head towards the N95 of the end of the spectrum and less towards the gaiter end.
All right, thank you. We have a couple more questions. People asking for a little bit more clarification or explanation on the mask mandate graphs that you showed. Their interpretation is that the mask mandates don't show significant differences. Can you just go over that again?
Sure. So when you look at those graphs, those districts without a mask mandate, the growth in cases on a daily and weekly basis is what we call exponential. It's a slope like this, meaning it's doubling constantly. The other slope is a much less slope. It's like climbing a bike or riding a bike up a hill. Do you want to ride up a hill like this, or do you want to ride up a hill like this in the plainest of terms? Is there still going to be transmission even in schools with mask mandates? The short answer is yes, of course, primarily because lots of activity happens outside of school that has nothing to do with the mask mandate in school. Transmission happens all over outside of the school, point one. Point two, not every mask is as effective as we just talked about. So does it reduce transmission? I think those two lines show unequivocally, both in Indiana and Georgia, that mask mandates do in fact change the slope of that line. And that's really what this is all about. It's about changing the slope. And those two lines are clearly different in both Indiana and Georgia.
All right, thanks for that clarification. We have a few questions about the third dose or boosters. Let's see, just in general, can you give us a definition? I know there's a difference between boosters and a third vaccine for immunocompromised. Can we talk about that a little bit? And I think that might answer a lot of the questions that are coming in.
Sure. So like most vaccines, each vaccine, depending on what it's trying to address, polio or in this case, COVID, the number of vaccines needed is different. Some vaccines are effective with one dose, some are effective with two, some with three, some with four. Polio is the case of four. With COVID, we are still in the learning process of what level of vaccine is necessary and how long does the protection last? Is it a 6 to 12 month window? Is it a much longer window? We're still in the process of learning and understanding that around the world. We're 8 months into people being vaccinated in this country, so that data is actively being collected. For the immunocompromised individuals, what we do know in those individuals is that their immune system isn't functioning properly. Many of them are on immunosuppressant drugs, meaning they take a specific drug to reduce their immune system so that it's, in the case of RA, for instance, you take immunosuppressant drugs to reduce your immune system so that it doesn't trigger significant inflammation. Those individuals, in order for them to have the same level of protection that, for instance, you and I have at the 80–90% level, they need 3 doses, as we now know, to get them up to that level. And that was what was approved in the last several weeks by the CDC and FDA to get them to that level. The difference between that and a booster shot, which is what you probably heard on the news over the last couple of days, is for individuals like us who are now 8 months, 9 months post-vaccine and want to ramp up our immune response to keep us at that level and above into the foreseeable future. That's the difference between a third dose and what is considered a booster, meaning it's boosting your immune system. Even though you have a robust system in response, it's taking you up and keeping you up at that level that you were already at. That's the basic distinction between those two. The one for immune compromised individuals is approved. The one for the rest of us has not been approved. The White House has suggested they want everyone to get one 8 months post-vaccine, but the FDA and the CDC still have to look at the data and actually approve it. Until that time, we cannot give a third dose or booster dose to individuals who were vaccinated 8 months ago.
All right. That helps clarify a lot of the questions I think that we were having come in. If someone is immunocompromised and is interested in getting that third dose, which is recommended, what is the process for them getting that third dose? Is there a list they sign up for? How do they get that dose?
So they just need to go to a location that is administering vaccine. Here in Clear Creek County, Idaho Springs, the Safeway has vaccines available. You go in, talk to the pharmacist, fill out the form. There are several locations also in Evergreen, the Walmart, the Walgreens, Safeway there as well. Many of them there's no appointment necessary. You just show up, present to them your medical case, fill out the form, and then you will get vaccinated with that third dose.
Do people have to show any proof of having an immunocompromised system to get that third dose?
They have to have a conversation with the person administering the dose. I'll leave it at that.
All right. And then, I'm sorry, did you give it, you were thinking it's probably going to be in September sometime when the boosters may be approved for people who are 8 months out from getting their second shot.
That's what the White House said. I'm waiting for the CDC and the FDA to speak.
All right, let's see. Will you recommend county employees be vaccinated with the boosters?
I'm sorry, say that again.
Will it be recommended for county employees to get the booster when it is available?
So my understanding so far, based on the conversation generally, is that it's going to be sequentially, meaning those individuals who were vaccinated first, in our case here in Clear Creek County, it's the first responders, and then moving down the tier. And the reason for that is it's when they're recommending 8 months post-vaccine, obviously as time goes by, more and more people as we move on. So it will be basically in the same order that we did the first round. We'll follow that. So, but again, until we get FDA or CDC approval, we can't administer doses as booster doses anyway.
Right. So it'll basically be following that same phased approach of the initial vaccines, simply because of when those initial vaccines were given.
Correct.
And just counting 8 months forward from that. And then again, with the boosters, same thing. You'll just go to wherever vaccines are available and get your booster. It's not a special process.
Nope.
All right. Let's see. We have a question about the case counts. Case counts are based on the tests. Are most tests PCR tests? How is it tracked about positivity depending on what type of test, or is it just any positive test that's entered into the system that adds to the case counts?
Yeah, correct. So COVID is a communicable disease, and in the state of Colorado, as in most states in this country, it is required that is reportable. So meaning if you get a PCR test, antigen test, whether it's at the hospital, your doctor's office, they have to report that result. That all gets entered into the state system. It doesn't differentiate. I don't see a differentiation in the data that I look between antigen test or PCR test or any other test. The only ones that wouldn't be in there is if individuals went to Walgreens and got a self-test and did it at home. And if they didn't report it, obviously we wouldn't know about it unless they contacted us directly.
Right. All right. And can you just talk a little bit about the accuracy of the different types of tests? Are there different accuracy rates for the different types of tests?
There are. There's as many tests as there are. Yeah. PCR is the best. It is 90+% accurate. It's the one that I would strongly recommend if you are going to get tested. The COVID Check Colorado that we have here available in our county is in fact PCR testing. It's either done through saliva or a nasal swab. Antigen tests, far less accurate, not as specific in terms of their accuracy. So you could in fact have a false positive with that test, and that would require typically when that happens, they would do another test with PCR to in fact validate the result that you did get. So yes, there are differences. PCR is, in my opinion, the gold standard. and would recommend that over the antigen test.
And then whenever a test is conducted, is the sample also being tested for the variant, or how are variants determined?
Very good question. So the state is actively drawing a subsample of all of the tests that are done in this state on a weekly basis. The state takes a portion of those and then does further analysis on them and analyzes them to look at any potential variation in that. They do that both the state lab here and at CSU, has some of the top virologists in the world, and they look at both of those and determine is it lambda, is it alpha, is it beta, is it delta, and then look at it even further than that. I won't get too far in the weeds, but that's basically how it happens. So it's a surveillance system, a portion of the total test done. They obviously can't, it's very time consuming, very expensive. And so they only do a portion of the test total that are done to look at that information.
I heard that CDPHE has a new data portal specifically about variants. Is that up on their website yet? Do you know? Are you familiar with that?
Yes, it is. I was told it was yesterday. I haven't had a free moment to go and verify if CDPHE has gotten it up on their website yet. But I was told yesterday that it was going up.
All right. So if anyone's interested in learning more about variants on this in the state of Colorado, you can get that type of information on the CDPHE website. We've got a comment and a question regarding events. A lot of big draw musicians and other entertainers have canceled concerts for this year or for the rest of this year. Would it be wise for local attractions and events to be doing the same?
All I can say is this. The Delta variant is a game changer, as we all know, and the level of transmissibility of that, the level of cases that we're seeing both in this county and across the state, and more importantly across the country, have the potential to create a super spreader event in any venue. Obviously outside, it's far less risky than an indoor venue. But again, I would highly recommend vaccinated and unvaccinated individuals to mask. It is an additional level of protection. I understand everyone's frustration and being tired of wearing masks. I am too. But the reality is they are protective. They do reduce the potential for transmission. And that is the entire name of the game. How do we reduce transmission in ways that are as effective as possible? So would I recommend going to a large event indoors? Absolutely not. Would I recommend going to a large event outdoors? It really depends on the venue. It really depends on a whole host of variables. If you do go to those things, I would highly recommend you wear a mask. Reduce your risk, both in getting COVID and giving COVID if you are one of those asymptomatic individuals.
Right. Yeah, I think a lot of people they need to determine their own level of comfort level with taking a risk, and they need to make those decisions themselves at a certain.
I think we might have lost Chris.
Yeah, I think she's frozen.
Oh no. I can ask some questions if you want.
Perfect.
Okay. Let me see if I can pick up where she left off.
Thanks everyone for your patience.
Yeah, thank you. So there was a question about the school district, and Karen Quambeck answered that 90% of the school district has been vaccinated, which is fantastic. Let me try to find where Chris was. I'm sorry, everybody. Employees in the school district will not be required to be vaccinated. However, they are at 90%, which is great. Just got a new one. When will we have sites in each community to get tested and to get vaccines?
Well, we reached out to COVID Check Colorado, which is the company that is in contract with the state, which provides our testing, asking them to provide us with a second location in Georgetown. That would provide Georgetown, Idaho Springs, and there's an abundance of opportunity in Jefferson County to the east of us. We have not heard back about that. When we do, we will let everybody know. As far as vaccines, we've been to every single corner of this county. Empire, Silver Plume, Evergreen, Idaho Springs, St. Mary's Alice. We've been to every single one of them over the last 8 months. So it's very time consuming and resource heavy when we go to a location and only 2 people show up and we sit there for 4 hours. So there's no shortage of vaccines available within 10 miles of most anyone in this entire county that are available 7 days a week. So vaccines are abundantly available. And in this country, we're incredibly privileged. We have 3 different vaccines to choose from, the likes of which no other country in the world. So having vaccines available within 10 miles of your home, I think is more than reasonable for folks to subscribe to self-preservation and go and get yourself vaccinated.
All right. Someone got the J&J vaccine. Do they have to wait for J&J to come out with their 3rd vaccine to be more protected, or can they get one of the other vaccine types?
It's a good question. J&J is similar to Pfizer and Moderna. They are actively collecting and actively looking at data to answer the same question that Moderna and Pfizer have answered already, that the FDA will obviously review. They're in the process of collecting that data and looking at it and determining if in fact you do need a booster shot or not. Until that realization comes out, it's going to be many months before anyone who had a J&J vaccine would even need a booster, primarily because we didn't start giving J&J until significantly after we started giving Pfizer and Moderna. So you're many months away from that reality. And by the time that comes around, J&J will have that data and the FDA will have looked at it and answered that very question. So premature at this time.
All right. Any other questions? Alyssa, is there info about COVID funds and improving our broadband? Yes, Rachel, please email me. Broadband is definitely one of the things that is included in ARPA. I'm going to put my email address again in the chat. And it's one of the things that we're really looking at trying to figure out a way to help. I also, Tim, I don't know if you're able to talk about the broadband at the clinic. I know a little bit, but I don't know. I'm not an expert by any means.
I am not either.
Okay, so I can talk a little bit about the broadband. I am by no means an expert on it. I do know that the new collaborative care clinic in Idaho Springs is a broadband hub for the community. The thought behind that, and CDOT has put some dollars behind this program as well. The thought behind that is that they have run fiber to the clinic, and then we will then be able to expand the fiber that is there, hoping to solve some of those broadband issues. It's going to take some time, and it's definitely an expensive project, but it's the start to something that we have not had previously. So not only is that clinic a hub for mental, physical, all kinds of different health related things, it's also a hub for connectivity. Are tests random and voluntary? I'm not sure I understand what that means, Jan. Do you mind expanding on what that means?
I mean, maybe she's wondering if what tests are available at different clinics. Can you choose what kind of test you want to get?
Oh, maybe.
I mean, they're definitely they're voluntary. Unless you unless your employer, or I think certain airlines occasionally require proof of vaccine or test. I mean, businesses.
Is it okay if I let Jan ask her question?
Mhm.
Okay, Jan, I'm gonna allow you to talk and you can ask your question. All right, you should just be able to unmute yourself and then you can ask your question.
Let's see.
Hopefully she can unmute herself.
Is it Jan?
Shirley,
Shirley.
Sherlaw, yeah. Yep.
Yeah, she should be able to. Let's just see. Well, so maybe let's just talk a little bit about tests. When you go to get a test, how do you know what test you're going to get? Different clinics will let you know.
Yeah, so here in Clear Creek County, the COVID Check Colorado test that they do is a PCR test. That's the level of analysis it's done. You have two options. It's either a nasal swab or you basically spit in a test tube. One of those two, but they're both run on PCR. It all depends on where you go. Some have antigen only, some have PCR testing. It's really going to depend. The CDPHE website, and we have a link to that on our website, of all the testing sites around. And when you click on them, typically you can see what they do in terms of what tests they have, whether it's nasal or sputum or what you would expect. So all that information is available. Many of them have a call number you can call and get more information at the specific site.
Yeah. We also have linked on our COVID webpage on the testing information page, a chart from, I believe it's CDC, kind of describing the different types of tests and how they're administered, what the accuracy is, that kind of thing. So there is definitely science-based information describing those types of tests. Let's see, someone is asking about the third shot. We've talked about the process for authorization. They're wondering if clinical trials similar to the first two shots have taken place, or are the boosters just grandfathered into those previous clinical tests?
No, nothing's grandfathered in. It's all based on data. It's data collected through the clinical trial, exactly as you asked. As I stated earlier, even though the White House says we want to give everyone a booster shot, it is not authorized. The FDA and the CDC need to look at the data to justify that. If they in fact find that there is data to suggest that there is a need for said booster shot, it's only then that they and they alone, not the president, not the governor, nobody, the FDA and the CDC are the ones who determine if the data justifies the need. It's only then that it would be approved. Hence my point of we can't give out a third dose to individuals until that's fully authorized by the FDA and the CDC.
All right. That's reassuring. Let's see. Can you talk a little bit about natural immunity with respect to being able to fight off viruses such as COVID and variants like Delta? Is there a natural immunity that is in existence or that we can strengthen somehow?
Yeah, so as far as COVID-19 is concerned, we historically we're what we call naive in the sense that we don't have any sort of immune response to it already. We haven't encountered it historically. Now, I get a little into the weeds. The first line of immunity comes in the form of antibodies. These proteins can attach to an invader like a virus, COVID, and either make it harder for it to attack cells or completely neutralize it, right? It comes in your body, the first line, boom, it kills it off. A vaccine boosts these levels of antibodies. Everybody is unique, obviously, but your immune response to things like this is also unique. Nobody knows what their response is going to be. That's why if you're going the natural antibody response and natural, I just want to get COVID and let my body fight it, you are taking an incredible risk. There's potential nothing happens to you. There's potential symptoms happen to you. There's significant potential you go to the hospital, and there's even more potential, like the 625,000 Americans who've already died, that you're going to die from it. Now, antibodies can stop viral infection quickly. And this production starts to wane over time, naturally, primarily because the body needs to make antibodies against other invaders, and there's only so much room in the body and only so much potential for your body to do that. Plus, some of these new variants that we've seen have evolved mutations that help evade your your normal antibody response. Now, there's a second line of defense involved, and it's the cellular response within us. The virus is attached to certain cells in the body and inject their own genetic material in them, basically hijacking the cell's natural function and forcing them to become virus factories. Now, immune cells called T cells can recognize these hijacked cells and work together to kill them before they produce more viruses. Now, B cells set up a longer lasting production antibodies and can help recognize and neutralize viruses also. Now, this longer term immune response is likely what keeps people out of the hospital. B cells and T cells cannot prevent infection, but they nip it in the bud and before basically people become severely ill. That's what happens when you have a vaccine. The vaccine basically is your antibody response on steroids. It's a much safer way and much more robust way to basically protect you. You go the natural route and you're basically taking a huge risk of, is it going to not impact me at all? Maybe. Is it going to kill me on the other end of the spectrum? Ask 625,000 plus Americans. The answer is, of course. And not all of those were individuals who were frail and old. As I showed on that slide, who's going to the hospital now? It isn't the elderly anymore. It's everybody below the age of 50 is who's going to the hospital and who's dying at this point.
Well, I think that it would be pretty persuasive information to a lot of people, hopefully, especially those age groups that are still having hesitancy in Clear Creek County. You gave us some numbers early on in your presentation. Can you remind us again, where are we at in Clear Creek County with our vaccination rate? How close are we to reaching community immunity just in Clear Creek County?
So we are at 61.2% of our community is fully immunized, meaning they've received either 2 doses of the Moderna or Pfizer or 1 dose of the J&J. We're at 65.8, so almost 66% have received at least 1 dose here in Clear Creek County. Are those numbers where we want them to be? No. Summit County, just west of us, is in excess of 85% immunized. So there's a huge difference among counties in this state. Some are in the high 20s, low 30s. Others are in almost 90% of their population are fully vaccinated. So that same thing is true across this entire country. It's why you are seeing massive pockets of COVID cases going on in the southern states, highly unvaccinated populations. This literally now is a pandemic of the unvaccinated. 99% of the population of those getting COVID at this point who are hospitalized or dying are in the unvaccinated. I don't know what more evidence you need to suggest that you should act in self-preservation and get a vaccine. I asked several people as they come to get vaccines, just curious as to what was the delay, what was their hesitancy. And I've heard more than a number of times of, I don't know what the long-term effects are. I don't know what this could do to me in the future. There's 2 things I would say, both of them are science-based facts. The first is, in all of vaccine development in this country and around planet Earth in human history, there have been no long-term effects associated with vaccines beyond the 60-day window. So there is no something that's going to happen to me 3 years down the road or 5 years down the road. The other fact is COVID is real. COVID is here. And if you get COVID, the probability of you going to the hospital or dying far outweighs any potential risk you may have with a vaccine. So one is, a real number, and one is I don't know if the number even exists sometime in the near or far future. Those two, a fear of something that probably won't ever happen ever, and something that is likely to happen in the near term, those two don't really go together. So COVID is real. The Delta variant has changed the game significantly. All you have to do is look at my presentation and the number of cases and the number of hospitalizations and the number of deaths that are occurring in this country right now, with only half of our population vaccinated. Those going to the hospital and dying are unvaccinated. They're not elderly, sick people. They are young, healthy people who are unvaccinated. And if that isn't reason to be interested in self-preservation, I don't know what is.
Right. And I think especially as you've pointed out, our 12 and under, our under 12 population is still not able to get vaccinated. So they're a very vulnerable portion of the population. And the longer the rest of us go without getting vaccinated, the higher chance they have of catching the COVID-19 virus. So as someone pointed out in the comments, this has been very informative, very sobering information, but I think very helpful and very hopefully motivational to people to continue to want to get fact-based, data-based information and to continue to ask questions and to get vaccinated. I'd like to remind people we were a little after 6 and we were scheduled to end at 6, so we want to be respectful of everybody's time. If you have additional questions that have not been answered, please check out our website at clearcreekcounty.us/COVID-19. We have a lot of information there. We also have a lot of contacts listed. We have Alyssa's contact information, my contact information, our public health nurses, as well as Rebecca Abrahamson, who is handling a lot of our business and event type questions. So we have a lot of information on our website. And we are here to answer your questions. We also have our COVID information line, which is 303-670-7528. And that is also listed on the website. I just wanted to remind everyone that our next town hall will be on September 16th. So we hope you can join us and keep asking questions, keep checking our Facebook and Nextdoor platforms where we continue to post more information. Thank you so much, Alyssa, and thank you, Dr. Ryan. And we will definitely see you next month at the next town hall.
Yeah, thanks everyone for joining.